Opioid use disorders and criminal justice. This is the first of two modules designed for helping criminal justice professionals work with opioid-dependent individuals under their supervision. The National Institute on Drug Abuse, NIDA, defines addiction as a chronic, relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disease because drugs change the brain. They change its structure and how it works. These brain changes can be long-lasting and can lead to many harmful, often self-destructive behaviors. While NIDA continues to use the term addiction to describe compulsive drug seeking despite negative consequences, the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, replaced the categories of substance abuse and substance dependence with a single category, substance use disorder. Addiction describes an inability to control the impulse to use drugs even when there are negative consequences. These behavioral changes are accompanied by changes in brain functioning, especially in the brain's limbic system, also known as the inhibition and reward center. Physical dependence is not the same as addiction. Dependence occurs because the body naturally adapts or habituates to regular exposure to a drug. Eventually, one may develop tolerance to a drug, a circumstance in which one's response to a specific drug is reduced, requiring a higher dose to achieve the desired effect. Opioid use disorders resulted in 18,000 deaths in 1990 in the U.S. In 2013, this number more than doubled, resulting in 51,000 opioid-related deaths. Agonist medications fully occupy and activate the brain's mu receptors. The primary agonist medication used to treat opioid addiction is methadone, a synthetic opioid. Let's hear a few words from Dr. Jody Rich about methadone maintenance.
Hi, my name is Jody Rich. I'm a professor of medicine at Brown University, and I'm going to talk to you about opiate use disorder and treatment for the next few minutes. I've been a consultant to the Rhode Island Department of Corrections for the last 22 years. I've been doing a weekly clinic there, seen many patients with this disease passing in through the criminal justice system. Opiate use disorder is currently an epidemic in the United States. We have an associated epidemic of overdose deaths, and the best treatment we have is medication-assisted treatment. I'm going to talk a little bit about the disease first and then get into the treatment. So this disease is really a disease in the brain. It impacts the part of the brain that's involved in the basic survival mechanisms. This is part of the primitive brain, the reptilian brain that's right in the base of the brain, not the cerebral cortex where we do all our thinking. Two things happen to your body physiologically when you take opioids regularly for on a daily basis for days to weeks. One is you develop tolerance, which means you need a higher and higher and higher dose in order to get the same effect. The second is the withdrawal phenomena. If you stop, you go into withdrawal. Now, patients describe withdrawal as the most horrible feeling they can imagine. Imagine the worst flu you ever had. It's 10 times worse than that. When you see somebody in the throes of withdrawal, they are curled up on the floor in the fetal position, just moaning, just saying, "Oh, make it go away, make it stop." That whole time they know they could just get a little fingernail full of this drug or medication into themselves, that the symptoms will resolve and will go away and they'll feel normal. And in fact, when people first starting using opiates regularly, they get a sense of euphoria, a sense of relaxation. Subsequently, as the tolerance increases, that pleasurable sensation diminishes. They need a higher and higher dose. But then when they try and stop, they go into withdrawal. It is this double reinforcement of the behavior that really, so it's a doubly reinforcing in that the positive effects when you use it, make you feel better, and the negative effects when you don't use it make you feel worse. That changes the wiring in your brain. So this primitive part of your brain that's involved in survival interprets the signals of withdrawal, saying to your body, you will die if you don't get this. So that is really what drives many of the crazy behaviors and desperate behaviors and illegal behaviors around opiate use disorder. All three of the medications used for medication-assisted treatment block that positive reinforcement and also address the negative reinforcement of withdrawal. I tell patients these medications will lift that monster off your back. It doesn't go away, it's there, and it allows you to work on your recovery. Now, recovery is like a compass heading. Recovery is a state where you're, instead of spending your whole time trying to procure and use drugs, you are spending your time on healthy pursuits, on being healthy, being honest with yourself, working on your relationships with other people, being aware of other people around you, and doing things to better yourself and your home and your community, and all the things we want people to do. And really they want to do too. Now, methadone has been around the longest. It's been around over 50 years. It was almost begrudgingly approved based on very clear data in very small, elegant studies that showed that when people took methadone, they did not die. Not only did they turn their behavior around 180 degrees, start behaving like normal citizens, they did not die. Methadone has been life-saving for generations now. Unfortunately, this whole disease, opiate use disorder, has a tremendous amount of stigma. The stigma extends not only to the individuals involved, their families, their communities, their neighborhoods, but also their care providers, the physicians and the treatment centers, including methadone. Now, when people take methadone, it's an agonist. It turns on the receptor. But it lasts a very long time in the body. So when it's adjusted properly, you can adjust it so that you're right in this normal zone, and you take it every day, and you can go about your business. And if you use heroin on top of it, you don't feel it. If you stop it, you do go into withdrawal. Now, that withdrawal I described when people use heroin is gone within about a week, for the most part. That doesn't mean people don't relapse, because they have many triggers that do stimulate relapse. But that means the physical symptoms are gone. Methadone, the symptoms are not as intense. They're not curled up on the floor, vomiting and having diarrhea and feeling absolutely awful. So methadone continues to be tightly regulated by the federal government, is only available to treat addiction through federally regulated methadone opioid treatment programs. And patients must go there every single day. Eventually they can work, if they go through enough meetings and counseling sessions, to get take-homes, they call it, and they can get 1 dose a week, and then 2 doses a week, and then 3 doses. Eventually they can go just once a week, but that takes quite a long time. So when I ask patients if they're on take-homes, and they are, that means they have done a substantial amount of work on treating their addiction. But methadone is highly effective at engaging people, retaining people, and getting them to reduce and stop their illicit drug use.
In summary, methadone is a medication. It is used for treatment of addiction to opioids and heroin, drugs that are used illegally. It is slower in onset and longer acting than heroin. When properly dosed, it prevents users from getting high. It reduces or eliminates withdrawal and craving. And it is associated with high functioning in contrast with heroin, which is associated with crime, addiction, and a poor prognosis for positive outcomes. Like agonists, partial agonist medications occupy the brain's mu receptors. The primary partial agonist medication used to treat opioid addiction is buprenorphine. Naloxone is typically added to buprenorphine formulations to decrease the likelihood of misuse. Dr. Alan Weiner is here to share some information with us on the use of buprenorphine for the treatment of opioid use disorder.
My name is Alan Weiner, and I'm a family physician. After 20 years in primary care, I became an addiction specialist. I work for an organization called Clean Slate, primarily doing outpatient medication-assisted treatment, or MAT, for opiates and alcohol. We now know through extensive scientific research that opiate addiction, or OUD, opiate use disorder, is a chronic relapsing brain disorder. Let me emphasize, it is a chronic illness, not an acute illness that resolves with quick treatment. Addiction spares no one. It cuts through race and class. It is a complex formula of genetics, early trauma and stress, the social context of initial use, and psychological conditioning. And just as we would not deny our patients with hypertension or diabetes the medication they need, nor should we deny our patients with OUD the medication they need. There are 3 FDA-approved medications available to treat opiate use disorder. Let's discuss these medications. The 2 medications that are primarily used to treat OUD are methadone and buprenorphine, or as it is commonly called by its product name, Suboxone. They are long-acting medications, which is critical as opposed to the negative effects of short-acting opiates, such as heroin, which are so damaging. Buprenorphine has very unique properties that make it desirable for many patients. Like methadone, buprenorphine occupies the mu receptors in the brain and thus prevents other opioids such as heroin or oxycodone from activating those same receptors. Essentially, this means that if a patient uses heroin or oxycodone while taking buprenorphine, they will not get high, since the other opioids can't activate the mu receptors. It's like a key in a lock. With buprenorphine in the lock, other opioids cannot enter. Additionally, there is a ceiling effect, which means that after a few days, the buprenorphine level reaches a plateau, and the patient no longer experiences withdrawal symptoms. The ceiling effect, which means that more medication is not better or has a stronger effect, lowers the risk of misuse, overdose, and side effects compared with full agonists. For many patients, buprenorphine is also preferred since it can be prescribed by a qualified office-based physician and does not require daily or frequent visits to a clinic as does methadone. Due to the positive attributes of buprenorphine as one of the treatments of choice for OUD, it plays a critical role in supporting a patient who is committed to recovery. It's not the only piece. MAT, in combination with counseling and behavioral therapies, provides a whole patient approach to substance use disorders. MAT provides the foundation. When used to treat opiate addiction, MAT stabilizes the brain chemistry, blocks the euphoric effect of opioids, the high, relieves physiological cravings, and normalizes bodily functions. Once the brain chemistry is stabilized, which begins very shortly after starting treatment, the patient is alert, clear-minded, and can begin the recovery work. My patients range from the disabled, the unemployed, the employed in diverse jobs, from healthcare including PCAs, nursing assistants, nurses, counselors, also construction, manufacturing, sales. In conclusion, numerous studies, as well as my 6 years of clinical experience in addiction medicine, show that MAT reduces illegal drug use, disease rates, overdose, mortality, and criminal behavior. As part of an integrated program, MAT is absolutely vital in supporting our patients in their recovery, allowing them to reintegrate and become productive members of our society.
The use of buprenorphine is significantly better than counseling alone in keeping patients in treatment. In a study conducted in 2003, 3/4 of patients receiving buprenorphine and counseling were still in treatment after 1 year. None of the placebo patients were retained in treatment. Antagonist medications like naloxone and naltrexone block the effects of opioids by attaching to the opioid receptors without activating them. Dr. David Gastfriend is here to tell us more.
Hello, my name is David Gastfriend. I'm an addiction psychiatrist, and I taught for many years at Massachusetts General Hospital and Harvard Medical School, and conducted research as scientific advisor at the Treatment Research Institute in Philadelphia. I'd like to talk to you about extended-release naltrexone, also marketed under the name Vivitrol. This is a non-agonist, a blocker, or an antagonist. And it's different from methadone, which is a full agonist, or buprenorphine, which is a partial agonist. The brain has many different regions that have different functions. Some are involved with impulse control, others with stress coping, others with novelty seeking, and finally, reward sensitivity. All of these regions have to operate with full function and balance for healthy behavior, and we can impact each of these in various ways. Extended-release naltrexone is a month-long opioid blocker. It's a competitive blocker, so it is very potent, and it will block all the other opioids. It'll block buprenorphine, fentanyl, any of the powerful opioids, even OxyContin. Why was it created? Well, it was requested by the National Institute on Drug Abuse of the NIH because oral naltrexone had been tried in many studies and essentially did not improve retention or abstinence rates. Extended-release naltrexone is a once-a-month injection in the buttocks, and it lasts for at least 30 days. And it requires that the patient be opioid-free, because if the patient has opioids in their system, those will be knocked off by the naltrexone in Vivitrol, and that will produce a precipitated withdrawal. So first, the person must undergo a full detoxification. It is safe. It's safe for hepatic illness if it's chronic, hepatitis. It's safe in terms of withdrawal. It doesn't have a withdrawal at the end of the treatment cycle. So when the patient is coming off of extended-release naltrexone, they don't go into withdrawal, as they would with methadone or buprenorphine, and therefore they don't provoke their own relapse with withdrawal. It's not a controlled substance, it has no street value, there is no diversion, and it is not reinforcing on a daily basis because it's not taken on a daily basis, and it doesn't have even the mildest of effects like an opioid. It's also the treatment of choice for opioid and alcohol combined dependence because it also reduces alcohol consumption in alcoholics and promotes abstinence in alcoholics. So if the patient has both disorders, alcohol and opioid disorder, that's the treatment of choice. In brain research, we can actually scan while a person is looking at pictures of their favorite drug, and we can see what regions of the brain are lighting up. We actually find with extended-release naltrexone that opioid addicts have markedly diminished activation of their brain reward regions and hunting and anticipatory regions, but they also have improved function in regions associated with reflection and planning. So this is actually a potential asset for doing counseling. Who is extended-release naltrexone really for? Well, it's for the patient who's motivated to undergo detox. It's for the person who wants to be opioid-free. If they're getting ready to leave jail or rehab, if they're going to be monitored, if they have to undergo urine testing that can't be positive for an opioid like methadone or buprenorphine. And it's for the patient who has had agonist therapy before, like methadone, and has not done well on it, or who wants to graduate from it. It's for the patient who wants a shorter-term medication that won't make them physically dependent, because it doesn't do that. It's for late adolescents or young adults who may not have a long-term history of their addiction. What does it do to treatment and self-help? Well, it is only a chemical foundation for recovery. So its purpose is to support counseling, and rehab. And in fact, in a study, we were able to find in alcoholic patients who were on Vivitrol that they actually went, if anything, to as many or more self-help meetings than people who were on a placebo. What do we know about this in the justice system? Well, we've done a pilot study in Michigan and Missouri drug courts. In those drug courts, patients who had conventional treatment in the usual system with all of the supports and sanctions and monitoring of the drug courts had a 26% re-arrest rate in the next year. Compared to that 26%, the patients who were receiving Vivitrol had an 8%. So 26% for the usual treatment model, 8% when you add Vivitrol to the criminal justice program. And what about death rates? Well, death rates are known to be 12 times higher, at least, than the general population in people leaving jail who've had an opioid use disorder, and it's in the first few weeks. When you provide extended release naltrexone upon release from jail, so far we have not seen substantial death rates or even overdose rates. In fact, in a multi-site trial, randomized controlled, there was significantly better retention and reduction in relapse rates in patients who were randomly assigned to the extended release naltrexone. So the conclusion, when we look at the data, is that while opioid use disorder is a chronic disease needing long-term rehabilitation with both medication and counseling, the goals of treatment and rehabilitation are to save lives, to stabilize behavior, and to establish social function. Extended release naltrexone is superior to counseling alone. I've seen this many times, and the data support this consistently. It has no street value. It has no reinforcement, no diversion. There is no withdrawal from it after treatment. The higher initial cost can result in lower costs down the line. Therefore, cost should not be a barrier to providing treatment with extended release naltrexone. And remember, if one of these agents is unsuccessful, we have other choices. So we always have the option and obligation to consider other approaches if one has not done the job.
Opioid addiction is a treatable chronic disease that can be successfully managed. As we've heard from our experts, research shows that combining medications with behavioral therapy is the best way to ensure success for most patients. The most successful treatment is tailored to address an individual's drug use patterns and drug-related medical, psychiatric, and social problems. Relapse rates are similar to those for other chronic medical illnesses such as diabetes, hypertension, and asthma, which also have both physiological and behavioral components. However, medication-assisted treatment for opioid dependence and addiction has demonstrated far greater efficacy in reducing relapse than behavioral approaches alone. No single treatment is right for everyone. Identifying the best medication for any individual is the challenge of treatment professionals. However, one thing is clear. Opioid-dependent persons who are treated with medication are less likely to relapse, overdose, or die than those who are treated without the use of medications. In our next module, we discuss how the challenges and responsibilities faced by courts in providing access to medication-assisted treatment have been addressed by criminal justice professionals.